Chapter 17, the hip joint. The hip joint is the articulation of the acetabulum of the pelvis and the head of the femur. Our acetabulum is going to make up our concave surface, and our head of our femur is going to be our convex surface, so that's our rounded surface. The articulation of the axial skeleton and the appendicular skeleton happens at the hip, so this is where our trunk meets our lower extremity. The hip is a synovial joint. It is also referred to as a ball and socket joint because it is a ball-shaped femoral head with a socket-shaped acetabulum. And it is a triaxial joint with 3 degrees of freedom. Motions occurring at the hip during closed kinetic chain movements is where we would see the pelvis moving on the femur, so the foot is stabilized and the trunk is moving. In open kinetic chain movements, we see the femur moving on the pelvis, and that is where our trunk is fixed and our foot and lower extremity are moving. For closed kinetic chain movements, we're going to see our concave surface moving on our convex. For open chain motions, we're going to see our convex surface moving on our concave. Motions that happen at the hip are going to include flexion and extension, so forward motion would be flexion, posterior motion would be extension, occurring in a sagittal plane about a frontal axis. Our average normal degree range of motion for hip flexion is going to be 0 to 120, and then we should have 0 to 15 degrees of extension at our hip. For AB and adduction, those occur in a frontal plane about a sagittal axis. We have 0 to 45 degrees of abduction and 0 to 25 degrees of adduction. Medial and lateral rotation, or internal and external rotation, occur in a horizontal plane about a vertical axis, and we have 0 to 45 degrees of each of those. I don't really like this picture, so I'm just going to talk about the arthrokinematics of the hip in the text on the next slide, but if this picture helps you to understand what's happening, please by all means use it. Arthrokinematics of the hip that we're discussing here are going to be open chain movements where we have our our convex femur moving on our concave acetabulum. Your textbook defines flexion and extension as being a spin. Clinically, we can consider flexion as being an anterior roll with a posterior glide and extension as being a posterior roll with an anterior glide, but your textbook officially defines flexion and extension as a spin. Abduction happens when the femoral head rolls superiorly and glides inferiorly. Adduction happens when the femoral head rolls inferiorly and glides superiorly. Medial rotation or internal rotation is when the femoral head rolls anteriorly and glides posteriorly, and lateral rotation is when the femoral head rolls posteriorly and glides anteriorly. I acknowledge that arthrokinematics of the hip can seem a little bit tricky because of the angle of movement, the position that we're starting the patient in, whether that's from anatomical or a seated position, and the angle of inclination at the head of the femur. If you are having difficulties with this, come see me with one of the little skeletons, and we will keep playing until it makes sense. Our end feel for hip is going to be firm in all directions except for flexion. For flexion, we have a soft end feel because of soft tissue approximation of the thigh meeting the abdomen, but for all other motions of the hip, the structure of the joint capsule results in a firm end feel for everything else. The closed pack position of the hip, so where we have the most bony approximation, would be full extension and internal rotation, and if you place your hip in that position, so you kick back and point your toe in, you can feel how that femur kind of tightens into that acetabulum. The open pack position, so where we have the most freedom of movement and the position we would want to put patients in to perform mobilizations, would be 30 degrees of hip flexion, 30 degrees of abduction, and a slight external rotation. Capsular pattern movement loss that happens at the hip is flexion followed by internal rotation and then abduction. Innervation of the hip is going to involve a couple of nerves. The first one here is the femoral nerve, and we want to think of the femoral nerve as the nerve responsible for hip flexion. We see innervation here to iliacus and psoas major, which fuse to form iliopsoas, which is a hip flexor muscle. We can also see innervation to the rectus femoris portion of our quadriceps, which crosses the hip to contribute to hip flexion. So our femoral nerve is our nerve associated with our hip flexors. Our obturator nerve innervates the hip adductors, and we can see all of them except adductor magnus also gets innervation from the sciatic nerve. But all of our adductor muscles listed here, plus gracilis is our longest adductor muscle. It just doesn't have adductor in its name, but those are going to be innervated by our obturator nerve. The sciatic nerve runs the posterior thigh, and so it is going to innervate the hamstrings, the muscle that runs the posterior thigh. It also has contribution to innervating portions of adductor magnus, and we can try to remember this because adductor magnus is the only adductor muscle to also originate from the ischial tuberosity, which is where the hamstrings originate, and so because they have the same origin, they share some of the same innervation. Sensory innervation for the hip, looking at dermatomes, we're typically going to look at L1 and L2 involvement. For myotomes and motor performance, injuries to L2 would be hip flexion, and loss below that would further implicate hip function. Circulation is provided to the lower extremity via the femoral vein and artery, which enter the lower extremity via the femoral triangle. The femoral triangle is a space that's outlined by the pectineus muscle on the medial border, sartorius on the lateral border, and the inguinal ligament on the superior border, and it just creates a space for the femoral nerve, vein, and artery to pass into the lower extremity to provide blood circulation and innervation. Remember that our lower extremity can be broken up into segments, so our pelvis is officially part of our trunk, our appendicular skeleton, but it is our two innominate bones in our sacrum, and then that articulates with our femur, which creates the thigh portion of our lower extremity, and then distal to our knee but proximal to our ankle makes our leg, and then distal to our ankle would be our foot. Important bony prominences of the innominate for this chapter and in relation to what we're going to need to know for goniometry and manual muscle testing in the lab. I would familiarize yourself with the anterior superior iliac spine, the iliac crest, the anterior inferior iliac spine, the posterior superior iliac spine, and the posterior inferior iliac spine, and the ischial tuberosity. Looking at the lateral view of the innominate here, what I want you to pay attention to is where the acetabulum is outlined here in red. And we can see how we have all three portions of the innominate bone contributing to the positioning of the acetabulum. And so the hip is supported at this portion where it has all three bones meeting. And so that has both pros and cons to stability. If a large force then has the potential to disrupt those bones because it is at a fusion point, but because we have strength from all three bones being provided to the singular area of articulation, we do have support from multiple directions that allows us to handle most forces that we experience in life. Important bony prominences of the femur are going to include the greater trochanter, which you should be able to palpate on the lateral aspect of your thigh, and should know how to palpate on each other. This is going to be important for goniometry and manual muscle testing, and it is also important to know know it as a muscle attachment site for our glute med, our glute min, and most of the deep rotator muscles. Our lesser trochanter is going to be another important bony prominence for its muscle attachment purposes for iliopsoas. Our linea aspera is going to serve as an attachment point for our adductor muscles and the short head of our biceps femoris, so one of our hamstrings muscles. And it is also one of the bony landmarks that helps us identify the adductor hiatus, which we'll talk about in a little bit. The adductor tubercle is the other bony landmark that we need to know for our adductor hiatus, and this serves as a bony attachment site for adductor magnus. Remember, that is the adductor muscle that starts at the ischial tuberosity and running to the adductor tubercle. And our intertrochanteric crest is an important muscle attachment site for quadratus femoris. We will talk more about the tibia when we get to the knee a little bit later on in this lecture, but my guess for why it's included in this chapter is because the tibial tuberosity serves as the attachment site for the patellar tendon, which comes from our quadricep, which has rectus femoris that crosses the hip and contributes to hip flexion. Moving on to unique structures of the hip. We'll start off with the acetabular labrum, which serves a lot of the same purpose of the labrum of the shoulder. It's a fibrocartilaginous rim attached to the acetabulum, so it helps to provide the rim of articulation for the femoral head that both increases the depth of the acetabulum and the coverage of the head of the femur. We have our IT band, or our iliotibial band, which is a long, thick band of fascia that's located superficially on the lateral thigh. You can palpate your IT band running from your greater trochanter down to your distal to your knee, and it serves as an insertion point for part of our gluteus maximus and our TFL, or tensor fasciolata muscles. And so it's important to understand the implication of IT band adhesions and shortening on function for both of those muscles. Here's that adductor hiatus I was referencing earlier with the bony landmarks of the femur. So the adductor hiatus is the gap or opening within the distal attachment of adductor magnus between the linea aspera and the adductor tubercle, and it just serves as a passage point for the femoral artery and vein. Remember, those enter the lower extremity through the femoral triangle up at the proximal thigh, and this is located more distal in the thigh for the femoral artery and vein to continue passage to the popliteal fossa. Pes anserinae is another unique structure. Pes anserinae means goose foot, I believe, in Latin, but you'd have to double check me on the language. But it is a common attachment point for 3 of our muscles of the lower extremity. It is located on the anterior medial surface of the tibia and serves as the attachment site for sartorius, gracilis, and semitendinosus, which is one of our hamstrings muscles. This is the area that they will take a graft from for a hamstrings graft for an ACL repair. Because of the shape of our femur, there is this angle of inclination between the shaft of the femur and the head of the femur. And that's because our acetabulum sits laterally on the pelvis, and so the head of the femur has to be able to project medially in order to articulate with the pelvis, but also let our legs go down so that we can stand upright and walk and do all those fun things. So the angle of inclination in most people is 125 degrees. Somebody who has an increased angle of inclination, so that's a bigger angle between this, let's look at first the shaft here. Yeah, that line didn't go where I wanted to. So this being our shaft, and then this being our line through the femoral head. So this angle right here makes our angle of inclination, and that's the 125 degrees that we're looking at. Somebody who has a greater angle, so looking at going at this line up here, they're going to have coxa valga. So greater angles of inclination are going to result in the distal portion of the femur pointing medially. If you remember from our previous conversations in class, hold on, let me correct myself there. Coxa valga is going to result in the distal segment of the femur going more laterally. And so if you'll remember from our conversations in class, we drew on the board where the distal segment points medially, it's going to be a vera, and when the distal segment points laterally, it's going to be a valgus angle. The position of the hip is going to in turn influence the position of the knee and the position of the angle. So we're going to talk about these valgus and varus angles at each of these joints in the lower extremity, and I want you guys to be able to understand how they influence each other. And so I'm going to give you guys a drawing demonstration of this in class to understand how each influences the other. The important thing that I want you to take away from this portion is that the normal angle of inclination in the typically developing population is 125 degrees. Patients with an angle of inclination greater than 125 degrees are going to experience coxa valga. Patients with an angle of inclination less than 125 degrees are going to experience coxa vera. Again, because our body is designed to give the most efficient function, we have this torsion feature to our femur, to where the head of our femur sits in a different position comparatively to the shaft. And so the angle of torsion is the angle between the shaft and the neck of the femur in the transverse plane. So we measure the angle between the lines drawn medial to lateral through the neck and through the center of the femoral condyles. And there's a picture of this on the next slide. The head and neck rotation should be approximately 15 degrees anterior. So let's look at the picture and make it a little clearer. So in a normal angle of torsion, looking at picture A here, drawing a line through the condyles, we take a line through the neck, and that should be our 15 degrees anterior. So our femoral head sits anterior to our shaft in that rotated position. In patients who have a greater angle than 15 degrees, they will experience what we call anteversion. So anteversion is more forward positioning than the normal angle of torsion. And patients who have anteversion will have a resulting toe in, because if their femoral head points more forward, the femur is going to have to medially rotate in order to make it articulate with the acetabulum appropriately. And so with that medial rotation, it will produce a toeing in. On the flip side of that, patients who have a decreased angle of torsion, so less than 15 degrees, they will have retroversion, so placed more posteriorly than it's supposed to be, so retro. And that's a decreased angle, and it results in a toed out gait because the femur would have to externally rotate in order to appropriately position the femoral head within the acetabulum. Ligaments of the hip. So we'll start off with ligamentum teres. This is a very small ligament that runs from the both sides of the acetabular notch to the fovea of the femoral head. And there's a small blood vessel to the head of the femur that accompanies this ligament, and disruption to this ligament can often result in disruption to that blood supply, which can result in avascular necrosis to the femoral head. Our joint capsule is a strong, thick, and fibrous joint covering that is reinforced by 3 ligaments that each wrap around the joint to create tension for a different direction to produce those firm end feels for all motions except for hip flexion. The joint capsule most greatly restricts hip extension, and again, that's based on its design. Here we can see those 3 ligaments that reinforce the joint capsule. We've got our iliofemoral ligament, our pubofemoral ligament, and our ischiofemoral ligament. So each bone of our innominate has a ligament that runs to the femur to help encapsulate the femoral head. The iliofemoral ligament is also known as the Y ligament, and it spans the hip anteriorly in a spiral manner. It attaches proximally to the AIIS and divides into 2 parts, both attaching distally to the intertrochanteric line of the femur to make this inverted Y shape. So same proximal attachment, different distal attachments creates that inverted Y. And this ligament serves to limit hip extension. Our pubofemoral ligament spans the hip inferiorly and posteriorly in this spiral manner. Remember I talked about how they all wrap around. And it attaches medially to anterior and medial portion of the acetabular rim and the superior ramus of the pubis, and laterally to the posterior aspect of the neck of the femur. This ligament serves to limit hip extension and abduction. Remember, hip extension is the motion most limited by the joint capsule, and so all 3 of our ligaments serve to limit hip extension. Our ischiofemoral ligament spans the hip posteriorly and superiorly in a spiral fashion, attaching medially to the ischial portion of the acetabulum and laterally to the anterior aspects of the femoral neck. The ischiofemoral ligament serves to limit hip extension and external rotation. If you'll remember from earlier in the lecture, the inguinal ligament makes up the superior border to our femoral triangle, where our femoral vein, artery, and nerve enter into the lower extremity. Our inguinal ligament attaches to the ASIS and the pubic tubercle, so it spans those bony prominences. It is the landmark to separate the anterior abdominal wall from the thigh. The iliac artery and vein pass under them, and that's when they are renamed the femoral artery and vein. So the inguinal ligament is that kind of line of demarcation for where that change happens. Jumping on into the muscles. So iliopsoas is the first that we'll kick off with. And what I need you to know about iliopsoas is that it is the fusion of psoas major and iliacus together to form iliopsoas. So that is where the name comes from, is a portion of each of those muscle names. They come together to have a common attachment on the lesser trochanter. Iliopsoas is responsible for hip flexion and is innervated by the femoral nerve. Rectus femoris, we should be very familiar with this muscle by now. It is the only portion of our quadricep to cross the hip joint, and so we'll talk about it with the hip muscles here. What I need you to know about rectus is that it originates on the anterior inferior iliac spine to insert on the tibial tuberosity, remembering that it contributes to both hip flexion and knee extension. So understanding that its origin is above the hip and its insertion is below the knee can help you to connect those dots to how it contributes to both of those motions. And the rectus femoris muscle is innervated by the femoral nerve. I have a rule with sartorius. When you say it, you have to sing it. So sartorius. It is the seatbelt muscle, but sartorius means sartorial, coming from like a tailor, and so measurings for suits would be taken in this pattern running from the ASIS to the inside of the knee, and so that's where the muscle gets its name from. It is the longest muscle in the human body, and because of its line of pull, see how it kind of wraps across the thigh there? It causes hip flexion, abduction, and external rotation at the hip, and it also contributes to knee flexion because it crosses the knee to insert in our pes anserinae, and it is innervated by the femoral nerve. Pectineus is a small muscle of the hip. I need you to know that it contributes to hip flexion and adduction, which hopefully you can deduce from that superior medial line of pull, and it is innervated by the femoral nerve. Adductor longus is one of our adductor muscles. That means it's going to be innervated by our obturator nerve. It has adductor in the name, so that also means it's going to contribute to hip adduction. Adductor brevis is adductor longus's shorter brother. Remember that brevis means short, longus means long. Adductor brevis, again, has adductor in the name, so it's going to contribute to hip adduction, which means it's going to be innervated by the obturator nerve. Adductor magnus. So magnus means big, right? So magnus is so big that it has to be innervated by two nerves, both the obturator nerve and the sciatic nerve. And we can remember the sciatic nerve's involvement because it originates partially from the ischial tuberosity, which is the same place that our hamstrings originate from, and our hamstrings are innervated by the sciatic nerve. Adductor magnus is again an adductor muscle because it has adductor in the name, so it contributes to hip adduction. Adductor magnus is also the longest and deepest of our adductor muscles. We'll follow that up with gracilis, which is going to be the most medial of our adductor muscles. It is the only multi-joint adductor because it inserts on the pes anserinae, so we can see that it crosses the knee here. So it contributes to hip adduction and knee flexion because of its crossing of the knee joint. And it is an adductor muscle, so it is innervated by the obturator nerve. Gluteus maximus is our prime mover for hip extension. This muscle inserts just distal to the greater trochanter, but remember it also attaches to our IT band, and so IT band dysfunction can contribute to glute max, and glute max dysfunction can contribute to IT band. Remember, glute max is our prime mover for hip extension, so hip extension is our listed action, but it also contributes a little bit to lateral rotation, and it is innervated by the inferior gluteal nerve. Glute med, the most widely neglected muscle in the hip, is the prime mover for hip abduction. It has a pretty neutral line of pull with a slight advantage with a little bit of extension at the hip, and so it's important when we're looking at glute med hip abduction exercises that we have our patients lined up appropriately to be in that neutral plane at least, with maybe a little bit of extension depending on how much the patient attempts to compensate into flexion. We're looking at the glute med inserting on the lateral surface of the greater trochanter, and so it can often be implicated in lateral hip pain with trochanteric bursitis because of tightness or weakness in the glute med. On top of contributing to hip abduction, it also contributes slightly to medial rotation, and it is innervated by the superior gluteal nerve. And then its smallest cousin, gluteus minimus. Glute min is the deepest of the glute muscles. It contributes to hip abduction, not as substantially because of size as glute med. Again, a smaller muscle isn't going to be able to produce as much force. And it also contributes to medial rotation. It is innervated by the superior gluteal nerve, so it's nice that glute med and glute min have the same actions and innervation. Our deep rotator muscles are going to encompass all of the muscles that you see here, though I'm willing to bet that you are probably only really familiar with the piriformis that's shown here. So our deep rotator muscles, we're looking at piriformis, obturator externus, gemellus superior, gemellus inferior, and quadratus femoris and obturator internus. What I need you to know about the deep rotator group is that they all work together to produce external rotation, and that the reason you are probably most familiar with piriformis is because piriformis shortening due to weakness is most often implicated in this group of muscles. And remember that the sciatic nerve passes through the muscle bellies of piriformis and can be implicated there when we have muscle tightness due to weakness. Semimembranosus is one of our hamstring muscles, so it obviously originates from the ischial tuberosity. It inserts on the posterior surface of the medial condyle of the tibia. Semimembranosus is on the medial side of the thigh, so I like it because it's semimembranosus. It has a lot of M's in it for medial. Just seems like it's being friendly to me. It's deep to our semitendinosus, which is another part of our hamstrings muscle. And it inserts posteriorly to semitendinosus because it is deeper. It contributes to hip extension and knee flexion as a hamstring muscle and is innervated by the sciatic nerve. Semitendinosus is going to be more superficial to our semimembranosus, originating again from the ischial tuberosity to insert on our pes anserinae. It contributes to hip extension and knee flexion and is innervated by the sciatic nerve. Biceps femoris is going to be the last muscle of our hamstrings, and it attaches on the lateral aspect of the tibia. Again, coming from the ischial tuberosity for the long head, but the short head comes from the lateral lip of the linea aspera. So the long head contributes to hip extension and knee flexion, but the short head only contributes to knee flexion. It inserts on the head of the fibula and the lateral tibia. So remember that the fibula is the more lateral bone in our leg, and so that can help you remember that the biceps femoris is our more lateral hamstrings muscle, and it is innervated by the sciatic nerve for the long head and the common fibular nerve for the short head, which remember is a branch off of the sciatic nerve. TFL, or tensor fasciae lata, comes from our ASIS to run to our IT band, and it contributes to hip abduction and flexion. And so when we see patients doing hip abduction anterior to the neutral plane, where they're in some flexion, they're typically compensating with TFL. And so that's why we talked about the line of pull for glute med needing to have the extremity in line at neutral or loaded into a little bit of extension to eliminate that compensation. And the TFL is innervated by the superior gluteal nerve. With a single special test of the hip, we can place the hamstrings in a passively insufficient position and the quadriceps in an actively insufficient position. You guys should be familiar with what a straight leg raise is by now. But a straight leg raise is where we have hip flexion with the knee maintained in extension so that the hamstring muscle is lengthened over both joints. It limits range of motion at the hip flexion, so with the knee extended, we may have a firm end feel to hip flexion because of tension within the hamstrings. Because the hamstrings is being put in its most lengthened position, it becomes passively insufficient. On the flip side of that, on the other side of the joint, the rectus femoris is a two-joint muscle that's crossing the hip and the knee that is being shortened over both of those joints with a straight leg raise. And so rectus femoris is being placed into an actively insufficient position. This slide is a little bit of a revisit to those force couples for the pelvis. And so basically it's saying that muscles that move the femur in an open kinetic chain configuration are going to either move or stabilize the pelvis in a closed kinetic chain. And we can think about that when we think of the contribution of our hip flexors to an anterior pelvic tilt or our hip extensors to a posterior pelvic tilt. Other examples of that are right hip abductors control the position of our pelvis when we're standing on our right leg. So when our left leg is in swing or we are maintaining a level pelvis with our right glute med. Our right hip abductors and left quadratus lumborum act as a force couple for left pelvic elevation. So if we were hip hiking, we would have involvement of our right glute med and our left QL. And our hamstrings and rectus, again, act as a force couple that produces the posterior pelvic tilt like we talked about on the last slide. Common pathologies of the hip. Congenital hip dislocation is going to be someone who is born with a shallow acetabulum, so congenital meaning at birth. And so hip dislocations that occur as a result to the way that they were born with the formation of their acetabulum. This can be common in infants with abnormal muscle tone because as babies grow, the head of the femur helps to shape and deepen the acetabulum, and if it doesn't sit appropriately within the acetabulum, or if we don't have the proper muscle tone to make the head of the femur appropriately sit into the acetabulum, it won't grow with the depth that it needs to provide the stability that's necessary, and so then we get these risks of dislocation. Leg calf Perthes disease, also known as coxoplana. So this is where the femoral head undergoes necrosis, and it happens in young children. The head dies, revascularizes, and remodels, but typically is misshaped or misformed after remodeling. We also have slipped capital femoral epiphysis, which is the proximal epiphysis slips from its normal position. And this happens to children during growing years where we see that head of the femur above the epiphyseal line slipping, typically inferior because of the body weight of the trunk with the articulating pelvis. Coxa valga we talked about with that angle of inclination. So we see coxa valga when we have an angle of inclination greater than 125 degrees, and this can contribute to congenital hip dislocation if a child is developing with an increased angle of inclination. Then again, that's going to affect the shaping of the acetabulum and whether or not it's going to provide the appropriate support. But anyways, when we see coxa valga at the hip, we typically can end up seeing a genu varum at the knee. So that's that compensatory change. And this is what I want to illustrate for you guys in class so that you can see how each of the joints balance each other out, trying to make this zigzag going down the body when we have a malalignment starting proximally. Opposite to coxa valga is going to be coxa vara, and so this is where our angle of inclination is less than 125 degrees, so that the distal end of our femur points more medially, so that we result in a compensatory genu valgum. Either condition results in weight bearing not being on the appropriate surfaces of the hip joint and can result in changes in range of motion. Because of weight bearing not occurring on the proper portion of the hip joint, it can also result in changes in arthrokinematic motions and creates greater wear and tear between the femoral head and the acetabulum, making these people more predisposed to requiring hip replacements due to degenerative joint disease. Femoral torsion, remember we talked about that angle of torsion that exists between the shaft of the femur or running through the condyles and running through the head of the femur. Anteversion is an angle of torsion greater than 15 degrees, so the head of the femur sits more anterior than it's supposed to. And this will limit medial rotation because the femur is going to have to already start in medial rotation in order to appropriately line up with the acetabulum. And because it's already starting in internal rotation, it's not going to have as far to go. And already starting in internal rotation means that these people tend to toe in. Retroversion is going to be the opposite of that, where the femoral head is sitting more posterior than where it is supposed to be, so the angle of torsion will be less than 15 degrees, and we'll see a limit in lateral rotation or external rotation in these patients, again, because the femur is going to have to sit predisposed in an externally rotated position in order to appropriately align the head of the femur with the acetabulum. So when we're already moved into that position, we're not going to have as much range of motion to continue to go, and starting in an externally rotated position is going to set a patient up to toe out. Both are weight-bearing on inappropriate surfaces of the hip joint, which can contribute to the same problems that we talked about with our angle of inclination. Osteoarthritis is the degeneration of articular cartilage, typically seen in adults, causing pain and limited range of motion. Hip fractures can commonly happen in the intertrochanteric and femoral neck, just because these are areas of weaker bone and inability to tolerate specific stress distributions. They're often managed with ORIS and hip replacements. IT band syndrome is an overuse injury causing lateral knee pain It results of friction of the IT band as it slides over the lateral femoral epicondyle of the distal femur. It's most commonly related to glute med weakness on the same side. Glute med does not attach to the IT band, but it does attach at the greater trochanter where the IT band originates, and pulling from that direction because of weakness and tightness can then cause a greater pull at the IT band as it's stretched towards its distal attachment, and so weakness there can contribute. We can also see contributions from our TFL and glute max, which do attach to the IT band, and it is commonly associated with runners. Trochanteric bursitis is inflammation due to overuse. It is a common complaint by runners and bicyclists, and it occurs over the greater trochanter. A hamstring strain is a pulled hamstring, overload of muscle, or attempting to contract quickly. Typically happens in sports that require rapid acceleration. We can see a proximal hamstring strain at the attachment to the ischial tuberosity, or we can see a distal hamstring strain at one of the different insertion sites for the hamstrings, but because the hamstrings have 3 different distal attachments, we more commonly see a proximal hamstring strain. We can see patellofemoral pain syndrome, or PFPS, which is typically associated with weakness in the quad. And I guess that was it for my pathologies of the hip. So if you have any other questions on PFPS, again, in the name it kind of tells you what it is. It's patellofemoral pain syndrome. So it's pain happening between the patella and the femur, and that is why the quad is typically implicated, because that is where the quad runs. We will move on now to Chapter 18, the knee joint. The knee joint is the largest joint in the body. It is a synovial joint. It is a hinge joint. Even though there's slight movement in other planes, we primarily think of the knee as having only 1 degree of movement. The stability is provided by ligaments and unique structures of the knee, such as our meniscus, and it is a frequently injured joint. This is a picture of the knee joint. So we can see we have 2 different joint spaces, really. We have our tibiofemoral articulation and our patellofemoral articulation. So we have to consider our articulation between both and limitations that occur. While most of what we think of as knee function happens between the tibia and the femur, dysfunction between the patella and the femur can contribute to overall lower extremity dysfunction. Osteokinematic motions of the knee. Clinically, we are going to only think about flexion and extension. Your textbook dives into abduction and internal-external rotation of the knee, but clinically it is a hinge joint, and so we are worried about flexion and extension. We have 0 to 135 degrees of normal range of motion for knee flexion, and 0 to 10 degrees of hyperextension can be normal in most people. Not everybody has hyperextension, but up to 10 degrees of hyperextension can be considered normal. I don't want you to worry so much about the information for abduction or medial lateral rotation, because again, clinically we look at the knee as a hinge joint. End feel for the knee is we're going to have a soft end feel for knee flexion because of soft tissue approximation between the leg and the thigh. For extension, we should have a firm end feel due to tension in the hamstrings and the posterior joint capsule. The closed pack position of the knee, so where we have the most bony approximation, is going to be with the knee fully extended with tibial external rotation. At the patellofemoral joint, it's going to be full flexion. So we can see that those are kind of opposite closed pack positions. The capsular pattern for the knee is going to be loss of flexion before extension. Again, I'm not a huge fan of these pictures, so I'm not going to spend much time talking about it. But what I do want you to take note of here is that this talks about a roll, glide, and spin happening at the knee, and that's because the knee has what we call a locked-in feature, and we'll discuss that a little bit more. When we talk about the arthrokinematics, we're only going to think about the roll and glide. I don't want you to worry about the spin, but I do want you to know that the spin exists as a component of the locked-in feature of the knee. So the anterior posterior dimensions of the femoral condyles are larger than the tibial plateaus, and that's why we get some of that spin feature at the knee. But looking at the arthrokinematics just of the roll and glide because of flexion and extension, that's what we want to focus on. During open kinematic chain flexion, we have a concave tibia moving on a convex femur, so the tibia rolls and glides posteriorly. I'm sorry. Hold on. Okay, yeah, this slide's just written wrong. So I'm right. The concave tibia is moving on the convex femur, so we have the roll and glide happening in the same direction during open chain motions. So for knee flexion, the tibia is rolling and gliding posterior on the femur, and for knee extension, the tibia is rolling and gliding anterior on the femur. During closed chain, for knee flexion, the femur rolls posterior and glides anteriorly. So this slide is written correctly for your closed chain kinematic motions at the knee. And for extension, the femur is going to roll anteriorly and glide posteriorly during closed chain motions. Or for extension specifically, sorry. Again, because of the size and shape of the femoral condyles compared to the tibial plateau and to one another, this is where we get the screw home motion, or that locked in mechanism. And if you look in this picture, we can see the medial condyle is larger in surface area than the lateral condyle, and because of that, there's more space for it to keep rolling even when the lateral condyle can't roll. And so that's where we get this medial rotation of the knee as we move into extension. So since we get this medial roll of the femur as we move into extension during a closed chain motion, that means with an open chain motion we get this lateral roll of the rotation of the tibia in an open chain motion. And that's basically what all the words on this say. We see this happening at terminal knee extension. So that very last bit of knee extension is where you can observe the screw home motion. The rotation places the knee in the closed pack position. If you remember, the closed pack position is full extension with external rotation of the tibia, and so this screw home motion or locked in mechanism is what creates that closed pack positioning. To unlock the knee, the moving segment rotates in the opposite direction. So if I have an open chain motion, I would have to have a medial rotation of the tibia to move into flexion. If I had a closed chain motion, I would have to have a lateral rotation of the femur as I move into flexion. If you put your hand on your tibial tuberosity and the top of your femur as you move your knee in and out of that terminal knee extension, you can watch as your hand on top of your femur rolls medially at that last end range, and the hand on top of your tibia rolls slightly laterally at that last end range. I feel as though I already talked about these, so I'm going to move on. The femur is the longest and strongest bone in the human body. Bony landmarks that we're going to look at for the knee include the medial and lateral femoral condyles, which are going to be our articulation surface, our medial and lateral epicondyles, which are important for goniometry, and then our patellar surface so that we know where our patella articulates. For the tibia, we have our medial and lateral condyles that we can palpate. We have our tibial plateau, which articulates with our femoral condyles, our tibial tuberosity, which is our insertion point for our quadriceps tendon, and the crest of the tibia, which is that bony prominence all the way down the front of your shin. Our patella is this kind of triangular-esque shaped bone where it tapers down to a point at the inferior surface, and it has a smooth posterior aspect so that it can appropriately glide on that patellar articulating surface of the femur. The patella is a large sesamoid bone. It protects the quadriceps tendon as it spans the femoral condyles and helps to change the angle of pull of the quadriceps in order to give us more efficient knee extension. Normal alignment of the lower extremity is affected by joint structures, and if you remember earlier, I talked about how the knee can influence the hip, can influence the ankle, and it's a kinematic chain, right? So they're all connected, and we're going to have influences occurring at one are going to impact what happens at the other. Looking specifically at the knee, we can at least get some visuals here of what genu valgum looks like. So that middle picture there is normal alignment. We can see the line goes straight through the knee joint. If we look at genu varus on the left there, that's where the distal end of our distal articulating segment, so for the knee would be our tibia, points more medially. And our line going straight down from our hip ends up going on the medial aspect of the joint. For genu valgum, that's where the distal end of the distal articulating segment points more laterally. We end up having that line go through the lateral aspect of the joint. The medial and lateral menisci sit on top of the tibial plateau to provide a better approximation for the round femoral condyles on the flat tibial plateau surface, and they also serve to provide shock absorption at the knee. So the menisci function to increase congruency of the joint. They absorb compressive forces through the knee. They are crescent and wedge-shaped with a thicker outer border. They're attached to the outer border of the tibial plateaus, and each has an anterior and a posterior horn, like a little C. The top part from, looking at that last picture would be our anterior horn, and the bottom part would be our posterior horn. Each has, I just read that, and then the medial meniscus attaches to the medial collateral ligament, making it more susceptible to injury, especially as part of the terrible triad, which involves the ACL, MCL, and medial meniscus. It is not vascularized throughout, so its ability to heal depends on where the tear occurs. More closer to the center of the joint, we have greater vascularization to the meniscus, and so there's a greater propensity for the tissue to be able to heal. But the farther out we get towards the outer surface of the joint, the less vascularization that exists, and so the less likely the meniscus is to heal at that point. There are multiple bursa of the knee, but I like to think that they're pretty nicely named. So at our patella, we've got a suprapatellar bursa, which is above our patella. We have a prepatellar bursa, which is in front of our patella. And we have two infrapatellar bursa, which are below our patella, one that's deep and one that's superficial. And so I think that they're just named really nice and try to make it easy for you to know. But their point and purpose is to protect the tendons of the knee and decrease friction. Ligaments of the knee, we have our collaterals and our cruciates. So our ACL prevents anterior translation of the tibia, and our PCL prevents posterior translation of the tibia. So looking at this lateral picture, our ACL runs, let me grab a marker, from the posterior aspect of my femur to the anterior aspect of my tibia so that my tibia doesn't slide forward anymore. And my PCL, I'll do it in red, runs from the anterior aspect of my femur to the posterior aspect of my tibia to prevent my tibia from going backwards anymore. And you can see this cross that they make, and that is why they are named cruciate ligaments. Our medial and lateral collateral ligaments provide stability in the frontal plane, so they're going to run along the sides of our knee. Medial stability is provided by the medial collateral ligament, our gracilis, which is going to be our longest adductor and most superficial adductor muscle, our sartorius, which is the longest muscle in the body that straps across our thigh like a seatbelt, and our semitendinosus muscle, which is one of our medial hamstring muscles that attaches to our pes anserinae. All three of those muscles attach to the pes anserinae and contribute to medial stability of the knee. Lateral stability is provided through the lateral collateral ligament and the IT band. Posterior stability is provided through the cruciate ligaments and the gastroc and the hamstrings, so the muscles that cross on the posterior aspect of the knee. And anterior stability is provided by the quadriceps muscle. We talked earlier about how the patella makes the quad more efficient in its line of pull, and that's because the quad has to come down and around this patella, which increases I'll grab a different color here. If this is my center of rotation and this is my moment arm, I've now made the moment arm bigger compared to if my quad didn't have a patella there. So we'll use orange, and it just came straight down, like maybe a little bit further out, like this, to attach. Then I would have this shorter moment arm, which wouldn't be as efficient at producing torque. And so with less force, I can produce a greater amount of torque because of the patella increasing the moment arm for the quadriceps muscle. The Q angle of the knee is going to look at the angle between the line going straight down through the middle of the patella and the line running from the ASIS to the middle of the patella that helps us to look at the line of pull of the quadriceps. The Q angle describes the difference in orientation of the femur and the tibia. So the tibia is going to be oriented in that straight up and down line running from our tibial tuberosity through the midpoint of the patella, and then our femur has that angled inclination that creates our Q angle, and that's where we measure from the ASIS to the middle of the patella. In relaxed supine position, we want to draw two lines on the lower extremity, so we'll go from the ASIS to the midpoint of the patella and the tibial tuberosity to the midpoint of the patella and extend it proximally up through the body. And we want to measure the angle between the extended line and the line from the ASIS to determine the Q angle. Normal range of the Q angle is 13 to 19 degrees and is determined by the larger size of the medial femoral condyle and the width of the pelvis. Larger Q angles result in greater pressure on the lateral edge of the patella and the medial aspect of the femoral condyle. They also result in increased potential for a dislocation of the patella and increased stress on cartilage of the posterior surface of the patella. Muscles of the knee. Hamstrings. Contracting together, the medial and lateral hamstrings produce knee flexion and hip extension. When the medial hamstrings, the semitendinosus and semimembranosus, contract in an open kinetic chain, they produce medial rotation of the tibia on the femur. But when the lateral hamstrings, the short and long heads of biceps femoris, contract in an open kinetic chain, they produce lateral rotation of the tibia on the femur. These are important to understand for the mechanics of the knee and what we need to have happen, but they're not as important for motion that's existing at the knee in regards to flexion and extension. Looking at our hamstrings, we can see our semitendinosus and our semimembranosus on the medial aspect, with our semimembranosus being deep to our semitendinosus, and then on the lateral aspect we have our biceps femoris, the long head and the short head, with the short head being deeper to the long head. 3 attachments to the pes anserinae, so that medial medial anterior tibia at the proximal tibia for the attachment site for gracilis, semitendinosus, and sartorius is going to be pes anserinae, the goose foot, and because these are 3 muscle bellies coming into one fused tendon, it's a thicker tendon, and so that's where the graft is taken for a hamstrings tendon graft for an ACL repair. Our quadriceps muscle is going to be made up of 4 muscle bellies. Our rectus femoris, which is the only one that crosses the hip and is the most superficial of our quadriceps muscle. And then deep to those we have vastus lateralis, vastus intermedialis, and vastus medialis. Vastus lateralis is going to be on the lateral aspect, vastus medialis is going to be on the medial aspect, and vastus intermedialis is in between those two. All 3 of these portions of the quadriceps contribute to knee extension only because they do not cross the hip, and they are all innervated by the femoral nerve. Rectus femoris, on the other hand, does cross the hip, so it contributes to hip flexion and knee extension. It originates on the ASIS to insert on the tibial tuberosity and is innervated by the femoral nerve. Our gastrocnemius, or gastroc muscle, starts above the knee, so it originates on the medial and lateral condyles of the femur to insert on the posterior calcaneus via the calcaneal tendon. It causes knee flexion and plantar flexion because it crosses the knee, and it is innervated by the tibial nerve. If you'll remember from the peripheral nerve lecture, the tibial nerve, or the posterior tibial nerve, is responsible for muscles for plantar flexion. Line up our P's. So our gastroc and our soleus will be our tibial nerves. We also have our popliteus muscle that is innervated by our tibial nerve. And popliteus is a little muscle that helps to unlock the knee during the initiation of knee flexion. So it causes internal rotation of the tibia on the femur during the initiation of knee flexion. But beyond that, it does not have a great function. Plantaris is another muscle of the posterior aspect of the knee. Not everybody has a plantaris muscle, actually, so patients may or may not exhibit dysfunction with plantaris. It is a small muscle, so it doesn't do much to contribute to knee flexion and ankle plantar flexion, but because it is a plantar flexor, it is innervated by the tibial nerve. So if we remember that our femoral vein and artery exit under the muscle spaces in the adductor hiatus between the linea aspera and the adductor tubercle, the femoral vein and artery end up becoming the popliteal vein and artery, which we can see here running through the posterior knee space with the tibial nerve. And then the sciatic nerve branches into the tibial nerve and the common fibular nerve or common peroneal nerve that wraps around to the anterior leg on the lateral aspect around the fibular head. That popliteal space is created by muscular borders. So on the superior lateral aspect, we've got our biceps femoris blocking it in, and then we have our semimembranosus and semitendinosus on the medial superior aspect of our popliteal space. Then our inferior aspects are going to be made up by the medial and lateral heads of gastrocnemius. Innervation versus function, just breaking those nerves down for you, and there's some pretty easy actions. So our femoral nerve is going to innervate our muscles that cause hip flexion and knee extension, and our sciatic nerve is going to innervate our muscles that cause hip extension and knee flexion. Common pathologies of the knee. It's important for us to know that knee pain is often due to problems at the hip or at the ankle. So a lot of times the hip is going to be more often implicated, but we can have issues proximal or distal in the kinematic chain that influence the knee, and we experience knee pain as a result of that. Hip abductor weakness can be a huge contributor to knee pain because of how the positioning of the knee then ends up being with weakness of the hip abductors. And so we increase the stresses of the knee, producing more knee pain presentations when we have glute med weakness. Malalignment of any joint of the lower extremity can be congenital or acquired, so we can be born with it, or it can be something that occurs as a matter of how we develop or with injury. Long-term effects of malalignment are often pain, osteoarthritis, and loss of function, resulting in the need for joint replacement to restore function. Genu valgum is going to be, again, looking at the distal segment of the joint, pointing more laterally. We have valgus angles. When the distal segment of the joint points more medially, we have varus angles. So genu valgum is going to be our knock knee, where our knees come together and our ankles point away from each other. The knees touch and the ankles are apart. Contributing factors to genu valgum are loss of the medial collateral ligament integrity, loss of the medial meniscus, and a large Q angle. Genu varus is going to be our bow-legged, so where our knees are apart and our ankles are together. And the contributing factors to genu varus are going to be loss of lateral collateral ligament integrity and loss of the lateral meniscus. Genu recurvatum is going to be where we see hyperextension of the knee, where our knees bend backwards. The knee is extended beyond the normal range of motion during terminal knee extension, and you can assess my knees in class to see one that is normal because it was repaired surgically, and one that I have genu recurvatum in, where I have approximately 15 degrees of hyperextension the last time I measured it. Patellar tendinitis is also known as jumper's knee. We have tenderness of the quadriceps tendon between the distal patella and the tibial tuberosity in patellar tendinitis, also accompanied with inflammation. It is an overuse syndrome that typically presents with anterior knee pain with active knee extension and passive knee flexion at end range. So when that patellar tendon is being stretched to end range, or when we're actively pulling on that patellar tendon, we produce pain. Osgood-Schlatter's, I believe we've talked about before, but when you've got that really prominent tibial tuberosity, that's probably because you had Osgood-Schlatter's growing up. It is inflammation of the epiphyseal growth plate of the tibial tuberosity that occurs during growth spurts. It is an overuse syndrome, and it causes enlargement of the tibial tuberosity and presents with pain. The management is rest and trying to adjust tissue length. So if we have shortened quadriceps that are pulling on the tibial tuberosity with greater force, Wolff's Law is going to increase that tibial tuberosity bone development. If we can stretch the quadriceps to be the appropriate length and decrease the tension on the tibial tuberosity, then we can also help to address Osgood-Schlatter's. Patellofemoral pain syndrome we talked about briefly with the hip, also known as PFPS, is diffuse anterior knee pain of unknown cause. Can be associated with patellar tracking issues, with quad weakness, hip weakness. Several factors can play into it, and depending on patient presentation is how you would work to address it, but it's going to be the kind of widespread diagnosis given to that diffuse anterior knee pain. Chondromalacia patella is softening and degeneration of the articular cartilage on the posterior surface of the patella. If you remember back to the picture of our patella, we have that smooth cartilaginous surface on the posterior aspect so that we have smooth gliding over the femoral surface. And when we have chondromalacia patella, there's softening and breakdown of that cartilage. It's caused by abnormal tracking of the patella in the patellofemoral groove and can be exacerbated by an increased Q angle. Inflammation of the articular cartilage of the patella leads to degeneration of the cartilage and can result in pain and loss of function. Tears of the menisci are typically due to wear and tear. Injury to the medial collateral often results in tear of the medial meniscus because the medial meniscus attaches to the medial collateral ligament. Loss of the menisci leads to osteoarthritis because not only do they help to promote bony congruency, but they decrease shock and friction on the joint space and serve for shock absorption. Prepatellar bursitis. If you remember our picture of the bursa of the knee, and they're all very nicely named, our prepatellar is going to be in front of the patella. It is known as housemaid's knee and is inflammation of the prepatellar bursa, which presents with swelling and pain. And it's named based on the inability to bear weight on that surface of the patella. So, somebody who would be cleaning floors on their hands and knees like a housemaid would have potential inflammation of this patella, and that's where it gets its colloquial name from. Terrible triad, I mentioned earlier when we talked about how the medial meniscus is attached to the MCL and they can be involved in terrible triad injuries. Terrible triad injuries happen with a posterior lateral blow to the knee in a closed kinematic chain position, so with the foot planted, and there is a posterior lateral hit to the knee that causes a medial collapse. It tears to the anterior cruciate ligament, the medial collateral ligament, and the medial meniscus, and causes joint instability and pain. I believe this is the last slide for this video, so I'm not going to click next yet, just in case I'm wrong, or just in case I'm right. We will go over hip and knee goniometry and manual muscle testing in class, but you guys should have access to those slides should you want to review it in advance. I would take a look at your crash course and your Frith and Fawcett textbooks for goniometry and manual muscle testing of the knee to prepare you for lab. Make sure you write down any questions that you have over this lecture and bring those to class so that you can ask them. And play with your hip and knee and see if any of this stuff makes sense.